I'm Miss Market, and then I worked as a spokesperson for both the Milwaukee Police Department and for the Wisconsin Department of Justice. Oh, one chin, look how low he is. Oh, that's just that's a killer. Sorry. These are the things. I'm so pleased to be here today because my goal in life, ever since I started as a reporter, is to help people tell their story. All right, so that's the thing that I hope is the takeaway today from all of our great speakers, is that you will be inspired to tell the story. Because I'm struck by just the first two speakers today and how much they had to share with a room full of people that are all, doing this. We're all going, yeah, no, that's true. But obviously there are people who aren't in this room that need to hear these stories. So as someone who does this for a living, I beg you, please think of, let's think of ways for you to get out there and to tell this story. So I want to introduce you to our panelists today. By the way, I was doing a little reading. As a former reporter, I like to get out there and do a little research. And I thought, okay, well, I'm here to talk about, health equity. So I better watch the news this week, and so I can see all the stories on it, so I can be informed when I come here. So here's what I found from a week of viewing all of our news. The royal wedding is moving along pretty well. William is going to be Harry's best man. That was just announced this morning. And if the royal baby name breaks while we're up here talking about health equity, I will make sure that I jump in and give you that information. There's apparently a bar in West Dallas that has an unfortunate name. Want their name changed apparently, and that was a 2-minute story on the news. We also have to have crime of the day because we need to scare people as much as possible from coming into the city of Milwaukee. We've got your brawl at Burger King. That's always important. And then something about somebody from a basketball team trying to get a taco, couldn't get a taco. Didn't care that he couldn't get a taco. One guy cared that he couldn't get a taco. And then now, if the Bucks win tonight, everybody gets a taco. That story, my friends, that was 3 days worth of news stories, right? I am here to entertain you, but we also want to make sure that we see what is the one thing we can do today, because that's the theme. What is the one thing we can do today? So. What I would like to, there was a health story, I'm sorry. Curbing your salt intake can add years to your life, apparently. So, and I'm not going to do that. So,
she's honest.
I need somebody to do the chocolate is really okay for you. So I would like to introduce you to our wonderful panelists today. Let's see here. Where's Chris? Chris left me. Chris abandoned me. I don't have your bios. I just have the stuff we talked about on the phone. So I'm going to let you tell everyone, for just a quick second, who you are. I think this is a better way to do it. Yeah, Chris, I'm just taking over. Let's start by having each one of you tell us your name, tell us what your practice area is, and then let's talk about what we're talking about today, health equity. How is that playing out here in Milwaukee? So why don't we will start with Dr. Hamilton. We'll start with you. And if you're not a doctor, you're welcome.
No, I'm not a doctor.
Uh-oh.
I'm Rochelle Hamilton. I am the Director of Population Health for Ascension, Wisconsin, and I am a nurse and a social worker by background. And I'm trying to remember my bio, but I see a lot of my community partners in the room, so they can attest that I do work. So. But I have a background in oncology from acute care, ambulatory care, community care, a focus on chronic diseases and the management of chronic diseases, and a personal interest in health disparities and health equity. Being a resident of the city of Milwaukee, born and raised, and I never really thought about the fact growing up. I just thought about this yesterday when I was listening to some Marquette University students talk about being from the zip code that everyone is familiar with, 53206. And I just thought about it this morning to say, you know what, I'm from that zip code. I grew up in that zip code and just never really thought about that. So a lot of things sometimes come to light when you're in environments like this. So I'm really excited to see everyone here.
So how do you think how are you feeling that the issue of health equity is playing out here in Milwaukee? You know, what have you seen from your chair where you're working?
So Milwaukee, and I'll talk a little bit about some of the things that was presented in the previous presentation. We talked about segregation, but Milwaukee is a hyper-segregated city with concentrated poverty that breeds safety issues, concerns, access to care, that creates disparities in education, employment, incarceration, housing, literacy. And all of those things are huge health disparities that lead to infant mortality that was spoke about, the early onset of chronic disease at a much earlier age that people living in poverty face, the complexity with just managing that chronic disease, and then also what was mentioned, you know, the shortened lifespan for people living in poverty. So all of those disparities demonstrate the need for really a comprehensive, holistic approach to healthcare delivery that will be able to address all those disparities and then really take a deeper dive at the inequities that exist, because they do exist. They're very prevalent in the city of Milwaukee. And as a resident, as a person of color living in the city, sometimes it is discouraging to think that, will this ever change? Can we develop strategies and interventions collectively so that we can have a real impact? There's pockets of things that are going on in a city, but there's no comprehensive plan to combat poverty. And like was stated earlier, that is the only thing I personally think that will have a impact in health disparities and health equity in the city of Milwaukee. It has to be collective, comprehensive, and we all have to be working together towards the same goal in order to see a difference.
Great. Well, that's what we're going to talk about today. Let's hear from our next panelist. Tell us a little bit about yourself, and also if we can talk a little bit about how you, from your chair again, how you think that the issue of health equity is manifesting itself here in Milwaukee.
Absolutely. Good morning, everyone. My name is Michelle Graham. I am a family physician by background and proudly representing the Medical Society of Milwaukee as the current president. My day job is the Chief Medical Officer for United Healthcare for both our Medicare and commercial lines of business for Wisconsin and Michigan. And having lived here in the community for almost 10 years, I'm really proud to say that the background has brought me to a place to represent my physician colleagues. So a little insight into who I am, and then I'll talk about that community. Growing up in college, I was actually paralyzed, and I had never really had a medical issue prior to that. And I remember at one point my parents poignantly saying, "We have insurance, why can't you help her?" And from the time I actually had multiple surgeries, and obviously you can see I can walk again, I decided that I was going to dedicate my life to helping other people. because had my parents not advocated for me, and had we not had the means to do what they did, I wouldn't be here today, I wouldn't be a physician, and who knows what life would actually be like. My health, the community health, that of my family, it all would have been impacted. So that's the background I'm speaking from. I'm representing all of my thousands of physician colleagues. If you ask today, most of us, we went to medical school because we wanted to help people. Certainly why I went to medical school. And when I think about the challenges in the community and what really is going to make a difference, as Roche eloquently stated, this is a partnership. It's not about one person. No longer can a physician only in an exam room actually impact everything that needs to be done to help each and every person in our community. We're here to make a difference and a change, but we need those partnerships to make a difference. Unfortunately, these issues have grown and grown. As we heard earlier, policies have happened without the insights of maybe some of those who could have provided them that are the best. The voices of those who are suffering have not been heard. And I think a summit like this today really is about those partnerships and making a difference together in the community where we all live. These are our friends, our neighbors, and our future.
I'm no expert, I was only in journalism for like 26 years, but what a great story to tell, and what a great story to use to promote what we're talking about, today. Thanks for being here, Michelle.
So, good morning. Can you hear me? I have a very soft voice. And for those of you who know me, I'm so quiet. So I'm normally not this. I'm gonna come out of my shell though for about 5 minutes. Is that okay? So my name is Gina Green Harris, and I actually work for the University of Wisconsin-Madison School of Medicine and Public Health. And I share a couple roles where one, I am the director of the Center for Community Engagement and Health Partnerships. That was recently put in place by Senior Associate Dean Richard Moss, supported by, of course, Dean Bob Golden. And the goal of that organization is to create community engagement from the university perspective of the researchers and the clinicians who have an interest in engaging communities of color in research. So we want to do that through an equitable and a lens that is relative to the community. So that's relative to our conversation. I'm also the director of the Regional Wisconsin Alzheimer's Institute Milwaukee office. I know you're like, what does this woman really do? But by the time we end, it'll make sense. And so that it's been in office for 8 years where we've engaged the community around research in Alzheimer's disease. And then finally, I am the director of the Life Course Initiative for Healthy Families, which of course most of you know is an infant mortality program that is supported by the Wisconsin Partnership Program of the school to help support African American women and their families to have healthy birth outcomes. And that has been in existence since 2009. And we support that initiative by focusing on things such as policies, systems, and environmental changes, so that we actually are hoping to address the root cause. Now, I want to be clear that we do that through partnership and through complex partnerships through hospitals and working with we have a regional approach where we have life course collaboratives in Milwaukee, Racine, and Kenosha. And they are our boots on the ground to help us understand what are the practices that need to be in place to address policy systems and environmental changes. And so one of the things that, and I'm not going to take a lot of time, but I'm going to tell a story at the end, so give me a moment. I'm a preacher's kid, but I won't preach, if you can hear that. But I just want to say, here's a few things we think can happen. And I too am a native of Milwaukee. I was raised in Milwaukee. I've lived in Milwaukee. I've seen the culture of Milwaukee, but I actually left Milwaukee and went to Ohio for some time. And so coming back, I've noticed some things that are different in Milwaukee than other cities. So for instance, I lived in Columbus, Ohio, where in Columbus, Ohio, there is a integrated approach to living versus a segregated and hyper-segregated approach. And what that does is that it allows for housing issues to be addressed complexly across all communities, as opposed to being able to take out healthy eating in one community where you only are impacting one segment of the population. If you have integrated communities, you're no longer able to do that. Ohio has been very instrumental in actually creating new opportunities for infant mortalities, which I'll talk about later. And I'm just going to end with this. I believe in science. I believe in data. And I believe they have a very important role in all that we do. However, when the science and the data supersede the humanality and human approach to addressing these issues, we all lose. So who am I talking to? I'm talking to the folks who are the physicians in the room who are saying, but the data says if we do this. I want to talk about the families who are saying, I understand that you're my physician, but can you talk my language? Can you share the impact that are you understanding that there are no grocery stores in my neighborhood? So please stop telling me to buy healthy foods when I have to shop at a gas station and they're buying bananas from Aldi's that were rotten for 5 weeks earlier. So I just want to encourage us to think about when we're talking about how do we address this, let's address this in a systemic way where we're talking about changing how we're providing information to our students, our doctors, our nurses. How are we training our upcoming medical professionals? I'm going to stop there because I know I could go on, but I hope this will be helpful for you.
You did just fine. There's nothing to worry about. Next, Dr. Veronica Gunn. I found my notes, which is a wonderful thing. When we were talking before the panel, we all got together on a conference call, and we talked about the fact that children are the ones who have suffered the most when we're talking about this area. You lead the population health management, correct, at Children's Hospital, and and no pressure, but how are we doing?
Well, good morning, everyone. I am Veronica Gunn from Children's Hospital of Wisconsin. I am a general pediatrician by training and come from a health policy background. And thank you for saving me from having to follow preacher here. I just wanted to say amen, ditto, what she just said. We're good. But in all seriousness, we're all here because we know we're not good. And we know that we have a lot of room for improvement. So to your question about how are we doing for Wisconsin's children, anybody in this room can answer that question. Not so well. When we look at national data, the Annie E. Casey Foundation is a commonly used reference. They publish every year a report that assesses the health of children in the United States by state. And when you look at health outcomes for children in Wisconsin, back in the year 2014, we were doing really well. We were ranked, I believe, 10th in the nation. In 2017, which is the most recent report we have at this point in time, that health ranking has dropped to 28th. For a state that has improved overall in ranking in a variety of other areas. And you might ask, well, gracious, why is that? By and large, it is driven by our pernicious challenges with low birth weight, prematurity, and infant mortality, while we've held ground in a number of areas like child death, for example. But also it's because other states around us have continued to improve and gain ground while we have simply held still. And I'm a native Tennessean, and when I was in Tennessee state government, we would say, and my apologies, but we would say, thank God for Mississippi, because if not, Tennessee would be 50th. And I thought when I moved here to Wisconsin, I am moving to an advanced state that works across borders and has made many investments in children's health. And unfortunately, we've seen the state move backwards over the past few years. We all will talk later about what our respective organizations and what we all collectively can do to advance the health of children. But what brought me here to this is because Children's Hospital and Health System has made this commitment that Wisconsin's children will be the healthiest in the nation. And that is not only inspiring and aspirational, it is a goal that we all have to seek to achieve. And one way that we are trying to approach this is acknowledging we can't do that, we can't achieve that vision by just being an excellent healthcare delivery system. Much like Ellen Sexton was saying, you can't achieve your goal by just being a compassionate payer, correct, or insurer. So we have to find new ways, and that's what this panel here is about today. I will
Great, thank you
save
so
some
much.
time for John.
John, you come from a kind of interesting point of view. You had the department that Dr. Buzz Cooper ran, am I correct?
Yes, thank you, Ann.
So please tell us a little bit maybe about yourself, of course, and then a little bit about how you think that work has evolved.
Sure. Hi, I'm John Moyer. I'm a professor of general pediatrics, peds like Veronica, and I direct the Institute for Health and Equity at the Medical College of Wisconsin, which was founded by Buzz Cooper. From my clinical practice in Midtown, from my research at MCW, and as all you all know, low-income children and families experience an unfair burden of health disparities. Some examples are food deserts in unsafe neighborhoods associated with obesity, and lead poisoning and learning disabilities and attention deficit hyperactivity disorder. We can learn from others. For example, in Columbus, Ohio, as noted by Gina, and from other nations. The US spends 50% more on healthcare services. We spend 25% less on social services per gross domestic product, compared with the average at 10 high-income countries, according to a recent JAMA article. And our US poverty rates are 25% higher than those nations. So in order to improve our population's health, the scientific evidence suggests that we should invest more in policies that are listed on Geoff Swain's nice figure. And I want to specifically highlight ones that have a direct and beneficial impact on kids and their families. Earned income tax credits, like Geoff pointed out. Maternal and infant home visiting. WIC programs and SNAP programs for access to healthy foods. Family subsidies for childcare. Early Head Start programs, and of course, universal health insurance coverage. Happy to talk more about those opportunities.
Great, thank you very much, John, we appreciate it. You know, when we were talking before the conference, we were talking together about today's events and where everybody wanted to come from. Michelle, I was struck by something that you said during our conversation, which is you talked about the culture-related questions, the non-traditional physicians' work. And I found that interesting, and I think everybody here would find that interesting as well. Lots in the news these days about trauma-informed healthcare. I would like to hear you talk a little bit about our conversation about the words matter when we're talking with patients.
Sure, absolutely. So as physicians, as I mentioned before, and representing the medical society, and I look at all of our physician partners and we think about what is kind of traditional medicine. You know, we see patients in offices and EDs, et cetera. And then we think about what really makes us tick behind the scenes and how we're trying to really impact lives. There are a lot of other things that are playing into that role. So as recently described, sometimes physician voices, they can be very powerful, but they're underutilized in some of the advocacy work that we can do in those cases. And so as an example, the stories that we hear in those exam rooms and what can happen then transition that kind of cultural change that's needed. You know, if a mom's evicted from her home through no fault of her own because she was doing something right for her family, and then doesn't have housing for her children. And the reason that happened was because she approached the healthcare system to get health for the children in the first place. It's a whole different approach with a family like that, a mom, a patient, those children, to try to really impact how do we maintain that trust? How do we empower physicians with the words, the care, the understanding to make a difference for that family? When they first reached out, they were essentially left on the street because they were trying to get additional care. Mm-hmm. And how do we equip all of our physicians who now, you were talking about education and change. So we need different verbiage. We don't need to be asking if there's a problem. There is a problem. It's really, how can I help you with the problem that's occurred? And as children are growing up in poverty and being negatively affected by all of these social determinants, they're our future. And we heard today from Dr. Swain, we heard from Dr. Valente, that this is an ongoing problem. We have to change that culture so that it's not a hidden thing that we can't talk about. It's not the thing that the mom doesn't want to say what's happened to her and her family. It's not the conversation where when somebody's trying to say, okay, well, I don't understand, you're not taking your meds or your diabetes isn't controlled. Well, you want me to eat fresh greens and vegetables, but it's not comfortable for me to have that conversation to say, I don't have the money to do that, or where I live, it's the only place I can afford to live. Where I live is in a food desert, and there's really nothing I can do to change that. Doctor, can you help me? As physicians, there's nothing more heart-wrenching than not having a good answer to that. And that's where we need all of that partnership and culture change to equip us with how can we use our voices, a powerful voice indeed, to affect that change. The medical society has committed to working on social determinants to help empower our physicians to try to help make that change. And we're looking to all of our community partners to really help us with that.
So conversations, obviously, we need to figure out a better way, a different way to have the conversations that we're already having, right? You're nodding your head a lot there, Gina. Is that something that that you can speak to a little bit? These conversations that between the healthcare provider and the patient.
Yeah, so I think that, quite frankly, yes, we have to work collaboratively. So coming from the community perspective, right, we know that the community's language, along with the provider's language, the institution's language, right, there's this language barrier, there's a communication barrier, quite frankly, to your point. And so, yes, we know that if we're collaboratively working together, that's why it is so critical that all of us are in this room together to hear the same concerns, but then come up with common ways whereby which we can actually start addressing them with an intentional way. And so I agree, physicians have a role to play, and it is heart-wrenching to hear what the patients are saying, but you should have an access point for that patient to say, I can't resolve this problem, but this organization can, or this person can. Reach out to this group. And so knowing that as a resource, and all of us coming together to have shared resources across the spectrum is really going to be important and critical to work that we do. And so again, through the Life Course Initiative here in Milwaukee Life, they are working on that. I know Joy Tapper's over there. She's leading the Health Access Health Committee. And so there are many folks who are a part of that in this room. We know we're talking to hospitals, we're collaborating with them, but we also want to make sure that it's reciprocal, right? So that when the patient's coming in, you know what to give them, how to connect them, and then we have to do that by also engaging the families who are impacted by this the most. Oftentimes, I just read something really quickly, I'll share this. I was reading a magazine yesterday and they were talking about how to do just this work, engaging communities and develop new policies and procedures of how to actually reduce some disparities. And one of the bullet points at the end said, if there is enough time to engage the target community and get their feedback. That's the mindset we're trying to talk about working on.
You know, to that point, Roche, when we were speaking ahead of time about your strong feelings that we have to really get away from this cookie cutter approach when it comes to healthcare. And your point, I recall, was we need to do a better job of assessing the health literacy of patients and the people that we're working with. Speak to that a little bit.
Yeah, from a population health standpoint, we're really looking at how do we take care of populations of people, and that could be any type of population. With that, you really have to develop different strategies and interventions to really impact that community. So you have to know the communities that you're working in so that you can develop those strategies. A lot of times when you talk to healthcare professionals, they say, oh, I treat every patient the same. No, you shouldn't. Because every patient is different. the approach and the equity in how you treat that patient should be the same, but you really want to really recognize and understand the population of patients that you are working with, and what are the most effective strategies that's going to work for that particular patient population, and be willing to utilize those strategies and interventions. I talk a lot about literacy. I'm a big component of education. I mean, that's what we teach our kids. If you get a good education, you can pull yourself out of poverty. That's what you're taught. But what if you don't get that good education? Where does that leave our children? And we know that we are graduating children in the city of Milwaukee from high school who can barely read. Really? So literacy is very important. I have a particular patient that one of my care coordinators had been called to the ED to manage. He had multiple hospitalizations. She worked with him on what his treatment plan was. He went home, he got his medications, but he still came back into the hospital for symptom management, hospitalized again. She began to say, I'm looking at what is going on. You're filling your medication. You're telling me you're filling your medication. I'm trying to eliminate all these barriers that I know exist for you, but still we cannot get your disease under control, and you keep coming to the ED. She was like, I'm not serving you. She told the patient, I am not serving you well. So we have to be honest to say, I need help to understand how I can help you better. What is it that I'm missing? I'm checking the boxes. What am I missing? And because they've had multiple interventions and multiple encounters, they develop this relationship. A lot of healthcare is really about relationship building. So then he finally said, yeah, I get my prescriptions, but I don't take the medicine because I can't read. And I'm afraid that I will take the medication wrong and die, so I just don't do anything. That was 4 years ago. And that man has been coming to the hospital every 2 weeks for her to work with him and set up his medication. He has not been in a hospital since. So how do you really build those relationships with patients, understand what their needs are, and then tailor your interventions and how you deliver care for that patient?
John, one of the things that we talked about beforehand also was this idea of partnerships. That really speaks to what Roche is saying. You talked a little bit about partnerships between academia, the community. Can you talk a little bit about how those partnerships you think might help us get where we're trying to go today?
Sure, thank you, Anne. So it's vital that there's these really tight, trusting individual doctor-patient relationships, but the important context is having a community, a team that works together, both healthcare, social, educational services, to address some of these difficult issues. The institute that I directed, MCW, has a mission to improve health and advance equity through academic and community partnerships. And a really important part of what we do at an academic institution is research, building knowledge, discovery, exploring ways to make things better. So the approach that we take is to try to better understand the root causes of those disparities that have been described, and to study the effects of efforts to improve equity. So I'll give you a few examples. We get National Institutes of Health support. We also get Medical College of Wisconsin support to do studies that are very relevant to the things we're talking about today. For example, what are the effects of racism and segregation on breast cancer survival? What's the effect of culturally sensitive fish advisories on Native American diets? What's the impact of state Medicaid expansions or not expanding on diabetes care and outcomes? What's the effect of state policies on opioid use and the subsequent impact on HIV and hepatitis C infections? And what's the impact of policies and family resiliency on early child development? That's the kind of stuff that we do in partnership with community, the kind of community-engaged research we heard earlier. So we really anticipate that this kind of work can inform our approaches and the policies that we develop to reduce disparities and improve health equity.
Veronica, Children's Hospital obviously is on the front lines of what we're talking about today. You've done a lot of work, and a lot of the outcomes that you have that you found in the Central City neighborhoods. We were talking about the fact that those might be transferable to other health or even social service organizations. Can you share a little bit about that work that Children's has done that you think contributes to our discussion here?
Certainly. I'll share a few examples of not just work that we've done at Children's, but activities that other institutions can have that elaborate on what John was talking about partnerships. So one thing that all of us can do, healthcare, social service agencies, any population that touches families and kids, is can screen and connect. And let me give you an example of what I mean by that. We at Children's just analyzed 3 years worth of data of a practice that we have been putting in place in our primary care and specialty clinics, where as a matter of routine, every child, every family, screening for unmet resource needs like housing and food and childcare and transportation and jobs. And when families identify a need, they are met with a connector. This connector works with them in really capacity building ways. And I want to emphasize that for a second. One thing that is a risk about identifying and having conversations around inequities and disparities is that at times it allows us to segment populations and define them by deficits. And that is, I know that's not what we intend to do, and so we want to make sure that we also build upon the strengths of families and communities. So in this model, we work with each patient family who has identified a need to say, so John, I see you have identified you all routinely run out of food at the end of the month. Tell me more about that. How can we help you with this? What has worked in the past? So working to build his ability to meet his family's needs in a way that is achievable. And that, in that model, the navigator helps to build a social health plan with the family, which is then documented in the electronic health record so that all caregivers have access to the needs of this family and can continue to follow up to ensure that those needs are met. What we've learned after 3 years of this is that all families have needs, regardless of payer type or insurance status or geography. This is not purely an issue of the Central City, if you will, although clearly it is far more prevalent. Unmet needs are far more prevalent in impoverished areas. We also know that when we are able to screen and connect families with resources, it actually has an impact on health outcomes. So all of the literature and data that Dr. Swain shared earlier about the negative impact of unmet health needs, social determinants of health, negatively impacts our health. We now can show that when we address those, we can improve health outcomes and decrease the cost of care. So working to find sustainable ways to do that. Every organization can screen and connect. You don't have to have the resources to actually be the service provider. We were connecting with existing resources in the Milwaukee community. One other thing that every organization can do is use the data that we have together collectively to illuminate problems a little bit more clearly. I'll give you an example, once again from Ohio. This one is from Cincinnati Children's Hospital, where they mapped geographically where children who had asthma and who had been disproportionately admitted to their hospital with asthma, they mapped where they lived and simply found that there were commonalities in where these children lived. In many rental properties that were managed by the common rental property manager, They simply illuminated that, which allowed that property manager the opportunity to make changes in those properties that was negatively affecting those children's health. It also allowed those families to better advocate for themselves because they knew they weren't alone. And finally, the third thing that every single one of us can do, Dr. Graham alluded to this earlier, is use our voices effectively. And we'll talk a little bit more about policy later, but all of us you don't have to be a policy expert to inform policy. You simply have to ask the questions, whether that's within your organization or you're talking about administrative policies, or whether you're working for state government or one of our elected representatives. Ask, what will the impact of this be on children's health? What will the impact of this be on children's health? If you simply ask that question and follow through, you are more likely to have more thoughtful, informed policies than we have seen at times.
Thank you, Veronica. That's why it's so important that, the room is teeming with legislators and their staffers here in Pennsylvania. That was the funny part. Real close to the break. We're on the home stretch. The last thing, I think we'll just go right down the line and ask you each. We only have a few minutes for each of you. So I'd ask you just to finish with what is my favorite question whenever there is a panel, and that is, from your chair, from where you are sitting, whether it is a policy issue, whatever, if you think that there's something that our legislators can do, let's talk about, from your chair, what keeps you up at night. Rochelle. Oh, I know, Script Schmidt.
So many things, but fortunately, I'll always have the ear of one of our elected officials. So, and this keeps us both up at night because our household, we talk a lot about policy, since my husband is Ashanti Hamilton, the president of the Common Council. So he knows a lot about healthcare, and I know a lot about policy, and we talk about this stuff all day long. But what keeps me up at night is the fact that I can't see the change. I can't see change. And that keeps me up at night. And that's why I just want to circle back to being comprehensive so that we can really see an impact. And until we do that, we can't do these incremental little changes in certain areas. It has to be comprehensive from housing, safety, education, all of it together to really impact poverty. And so I'm hoping that the people in this room will take heed to the information that you hear today. Earlier, there was discussion about bias and implicit bias. I would like everyone in this room to really do a self-assessment on what are your biases that exist and how does that affect you personally and professionally as you live in Milwaukee and the surrounding communities. What are your actions going to be when you have to make a difficult choice that personally impacts you? And I'll give you one example. One quick question to you is, what are you willing to do to have an impact? If there was an open seat left in one of the best schools in your area for your child, you have all the resources, you have the family support, you have stable housing, you have the income that is able to support your family, would you be willing to give up that seat in that educational setting for a child that lives in the 53206 zip code?
Good answer, Shay, thank you. Michelle, what's keeping you up at night, and what mandate do you want to send our participants on with you?
Thanks, Ann. So, fairly simply stated, people are suffering. I went through that in my life, and not to the extreme of the people who are in this community. As physicians, my colleagues are burning out. Resilience is an issue within healthcare, and these kinds of challenges, unless faced, are going to create a continually increasing problem for our communities, for all the individuals in it, and for our healthcare providers, who unfortunately, based on the presentation even earlier, if there's a perception there are too many of us, that is a completely incorrect perception. There are not enough. The predictions are sad at the best for the future as our continuing population ages and disparities become increasingly, we're more aware of them, but I don't know that we fixed them. So truly what keeps me up at night is people are suffering, and we haven't found a solution for that. As mentioned earlier, we spend more money and we have worse health outcomes than almost any place in the world for the amount that we spend. That's a problem. And people are not going to keep committing their lives to trying to fix that problem that we're calling healthcare, but really it's the health of our nation, unless we collectively find partnerships to work together to make those relationships. When you're sitting there, we need answers. We need something to do with the child who's looking at us or the mom who's looking at us in need. Those relationships and communities with healthcare providers are some of the most trusted. But as I look at my colleagues and the challenges they're facing in the world of what I'll call healthcare business and trying to get through seeing a number of patients and dealing with the increasing demands and needs of those patients, we really do need those partnerships. As physicians, we have a strong and powerful platform of a voice because of those trusted relationships and the insights that we have. But we're always not seen as the advocates for these kinds of issues. How powerful could it be if those who are working on housing and transportation would reach out to a physician who has that background story to say, this is the real world, this is what I see every day. Together we are stronger, and I would empower and encourage all of you. That's something each and every single one of you can do, is make a difference in just one other person's life. And look at physicians for who you may have seen us 100 years ago when the medical society first started as those trusted community advocates and powerful voices to advocate for every person in our community, not just those who may have currently a lot of access to healthcare.
Gina, what's keeping you up at night, and what's the takeaway today?
So yeah, a lot of things keep me up at night. But I think I'll end sort with this. We're the champions. We all are saying we're champions, right? Because we're doing the work. We're in the trenches, and we know the issues. We say we're moving forward, but to your point, what has changed? So champions are active. Champions have to challenge systems. We say use our voices. What are we using our voices for? And how long will we kind of ever so gingerly walk around and walk to the issues and softly address the issues, as opposed to having the courage to push down the doors? And I say that, Life Course Initiative is committed. The UW is committed to addressing this issue. We cannot do it alone. We have poured dollars into this, but we too have the question, where's the change? And what are we doing to impact that change? Personally, what I think is we have to start really being courageous enough to use the word racism when it's uncomfortable. And not only use the word racism, but address it when we see it. We talked about voices today. And so it's nice to come here because we're in a shared environment with people who have like thoughts and we're think leaders alike. But what do you do when it's someone who totally disagrees with you and you take a step back because you're fearful of that spot being lost? What makes us different today from the civil rights movement years ago, they were willing to lose it all. Are we really willing to lose it so that our kids, remember, this is about the kids, the next generation. Are we willing to step out so that they can have a future? That's what keeps me up at night. And really saying to ourselves, this is impacting Black babies, Black mothers, Black fathers, sisters, and brothers. But the reality is, take a look at the opiate crisis, folks. It's impacting all of us. If we have the courage to address the issue in the community that we know and allow the families to speak this thing and live truth to power, all of us will benefit. So I hope to sleep tonight, but the odds are that I won't. So I'm going to end with that.
I respectfully disagree with my colleague here that she is not a preacher. What keeps me up at night is that kids often get overlooked. And in a time and in an environment where the tyranny of the urgent or taco gains more media attention than kids, it is problematic. When kids are generally healthier, less costly, our attention as policymakers and healthcare providers is on those that are driving costs. But I tell you, 100% of everybody in this room, 100% of CEOs and physicians and policymakers and persons with chronic conditions were at once a child. And if we can't find ways to invest in keeping our kids well, we suffer and will continue to suffer as a society. This is what keeps me up at night. What I would encourage all of us to do is two things. One is certainly use our voice, and I love the use of the term courage because it is courageous to speak up, and particularly at a time where it's not entirely safe, or it feels like it's not entirely safe, because we have become this binary, you're with me or against me society. We're not. Don't let yourself be defined by that. But the second thing I would encourage us to do is be willing to listen and not just speak and live your piece, but be willing to listen and understand that of your patient families, of your employees, of your coworkers, of your neighbors, of your kids. And when you're able to do those things, you will be able collectively again to affect change.
Thank you, Ron.
With respect to health equity, what concerns me a lot is the unjust mass incarceration of Black men and fathers, the unfair evictions of low-income women, and children. Please read Michelle Alexander's New Jim Crow. Read Matt Desmond's Evicted for insights about your action plan. We can overcome.
Right.
Please join me in giving all our panelists. Thank you all for your attention. I know being the panel right before the break after 19 cups of coffee is tough, but I'm glad to see that everybody stuck it out and stayed to hear all the important messages that you have. And what keeps me up at night is knowing that there are so many great stories out there to tell. If there are any media in the room, I know that the Business Journal is a good participant of this event, and I'm hoping that other outlets will come forward and say, interesting, let me talk with you. Because as we discuss what's going on in the city of Milwaukee, we discuss how to cover that news. When they're having those conversations in the newsroom, I have the feeling anyway that it's kind of always the usual suspects, right? When you're watching TV, it's like, they're interviewing that guy, they're interviewing that person again. And so there is an opportunity. Use your voice. What a great mandate. That's it. So thank you all. This was a great conversation. I encourage you to have conversations during the breaks. You might have sat with people that you knew, but maybe get out there and meet some of the other people. You like what a panelist had to say? Find them. Find them. Talk to them. The partnerships is the only way we figure all of this out. So thank you all very much.